Hi, my name is Maria Alejandra Troya, and today I'm going to talk about the treatment of HIV with AMIBT, oxycytovir, and dazavir with ribavirin. To begin with, we have the background. The interferon-free combination of the protease inhibitor ABT450 with ritonavir and ACE5 inhibitor oxycytovir, also known as ABT267, plus the non-nucleoside polymerase inhibitor dazavir, also known as ABT333, and ribavirin, has shown efficacy against hepatitis C virus or HCV in patients with HIV genotype 1 infection. In this phase 3 trial, we evaluate this regimen previous on 30 patients with HIV genotype 1 infection and no cirrhosis. Here's a video so you can have a better idea what I'm talking about.
Of the HCV polyprotein, and thus the hepatitis C virus, HCV, is one of the leading causes of chronic liver disease and is a leading indication for liver transplant. The current standard of care for the treatment of genotype 1 chronic HCV infection is a triple drug regimen of pegylated interferon plus ribavirin plus a protease inhibitor. Although effective in 68 to 75% of treatment-naive patients, the tolerability and dosing schedules of currently available treatment regimens may restrict use in some patients. The development of safer and/or more effective investigational compounds is ongoing. Our increasing understanding of the HCV life cycle has revealed a number of potential targets for pharmacologic intervention. The hepatitis C virus, a positive single-strand RNA virus, enters the body via the bloodstream and targets the hepatocytes. The virus binds to the hepatocyte via a specific interaction between the viral structural proteins and liver cell-specific receptors on the hepatocyte cell surface. The virus then enters the hepatocyte via receptor-mediated endocytosis. Once inside the hepatocyte, the viral membrane fuses with the endosomal membrane, releasing the viral RNA into the cell cytoplasm. The viral RNA then travels through the cytoplasm to the endoplasmic reticulum, where it is translated by host ribosomes, resulting in the formation of the hepatitis C polyprotein within the endoplasmic reticulum membrane. The resulting HCV polyprotein consists of 10 structural and non-structural proteins that play essential roles in the virus life cycle and represent potential targets for pharmacologic intervention. The NS3 and NS5B protein have thus been key targets for antiviral drug development. NS3 consists of a C-terminal helicase domain and an N-terminal serine protease domain, which, together with NS4A, is responsible for the cleavage of all downstream non-structural proteins, an essential step in the HCV replication process. The non-structural proteins, together with host proteins, form the replication complex that facilitates the production of new viral RNA. The newly formed RNA is then packaged and assembled into new viral particles, which are then released from the cell to go on to infect other hepatocytes. Agents being developed for use in the treatment of chronic hepatitis C include compounds that inhibit NS3 protease. Faldaprevir is an investigational NS3 protease inhibitor that has a linear tripeptide structure with a C-terminal carboxylic acid group, which forms a non-covalent complex with the active site of NS3 protease. This in turn prevents the cleavage of the HCV polyprotein, and thus the release of the non-structural proteins necessary for the production of viral RNA, resulting in a reduction in viral replication. Phase 2 studies with faldaprevir as a part of combination therapy with pegylated interferon and ribavirin have been completed. Phase 3 studies are nearing completion. The second non-structural protein that has received much attention as a potential target for pharmacologic intervention is the NS5B polymerase. The NS5B polymerase is the catalytic center of the HCV replication complex, where it is directly responsible for RNA synthesis. Like other viral polymerases, NS5B has the right-hand structure with palm, finger, and thumb domains. There are at least 4 allosteric binding sites on the polymerase, namely thumb pockets 1 and 2 and palm sites 1 and 2. The investigational agent BI-207127 is a non-nucleoside thumb pocket 1 inhibitor. By binding to the thumb pocket 1 site of NS5B polymerase, BI-207127 blocks the conformational changes to the enzyme that are necessary for RNA synthesis.
A total of 631 patients received at least one dose of the study drugs. The rate of sustained variable response in group A was 96.2%, which was superior to the historical control rate. Virological failure during the treatment and relapse after treatment occurred in 0.2 and 1.5% respectively on the patient in group A. The response rates in group A were 95% among the patients with HCV genotype 1A infection of 98% among those of HCV genotype 1B infection. The rate of this discontinuation due to adverse events was 0.6% in each study group. Nausea, pruritus, insomnia, diarrhea, asthenia occurred in significant more patients in group A than group B.
My name is Denise Harnoy, and I'm a hepatologist or liver specialist at the Mayo Clinic. This is an exciting time in the treatment of hepatitis C. Our current treatments for hepatitis C are interferon, which is an injection that's taken weekly, and ribavirin, which is a pill that's taken every day. Now, in patients who are genotype 2 and 3, the success of treatment with interferon and ribavirin is actually very good. About 70 to 80% of patients will successfully be able to eradicate the virus if they have genotype 2 or 3. But as I said, this represents a minority of patients infected in the United States. In the United States, the vast majority of patients are infected with genotype 1. Standard treatment with interferon and ribavirin is successful only in about 40 to 50% of people with genotype 1 hepatitis C, and that's where these new drugs are targeting. So these drugs were developed as the first drugs that were actually developed against the hepatitis C virus itself. These drugs will be used in combination with interferon and ribavirin. Their names are telaprevir and boceprevir. They're a pill, and as I stated, each one would be taken in combination with interferon and ribavirin.
In periods untreated patients with HIV genotype 1 infection and non-cirrhosis, a 12-week multi-rated regimen of ABT415, omisaptivir, and dazavir with ribavirin was highly effective and was associated with a low rate of treatment and discontinuation.
The clinician should consider when deciding whether to recommend that an HCV-infected patient should begin therapy, especially patients with challenging pre-treatment factors.
It's a very important question, but it really gets to one of my core beliefs as a clinician who's involved in this field, which is the overarching idea that all of our hepatitis C patients will be candidates for therapy. I don't think there's any such thing as a hepatitis C patient who, once these treatments are approved and available, should have therapy withheld for any but the most compelling reasons. Hopefully there won't be prohibitive cost constraints, but in terms of medical reasons not to be treated, I can only think of the reasons hepatitis C patients should be treated. Every hepatitis C patient, even if affected with only mild liver disease at a given point in time, has the potential to develop progressive fibrosis with all of its attendant possible complications. We've also learned to think increasingly of hepatitis C as a disease with systemic ramifications, including an increased risk of diabetes, certain kinds of lymphoid tumors like B-cell lymphoma, premature arterial sclerosis, neuropsychiatric problems like depression and altered cognition, and of course there's a public health problem in the sense that people are transmitting hepatitis C to each other. So to me, once we have the treatments that have appeared on the horizon, or in certain cases already have appeared, namely the oral interferon-free medications, all of our hep C patients are candidates for therapy. The major theme that has emerged in the last year or two is this marvelous leveling of the playing field for opportunity of cure across very broad populations, where there used to be sharp gradients between those who had a good chance of response, those who were blessed with genetic makeups that, for reasons that are still somewhat mysterious, predispose them to respond to interferon and do relatively well with it, and those who had a very poor chance of responding to interferon. That's all going away as these powerful antiviral drugs overcome host factors. So we're seeing treatment-experienced patients who've had very poor responses to interferon do essentially just as well as treatment-naive patients. We're seeing patients with cirrhosis, which is the most worrisome state of affairs for a hepatitis C patient, have cure rates that are very, very high as well, although there's still some question about the optimal duration of therapy with the regimen studied so far. We've seen HIV co-infected people or African Americans who have hitherto been disadvantaged in terms of the likelihood of being cured with interferon therapy achieve this state of leveling of the playing field of opportunity for cure. The only situations in which I could think of not treating patients is if, for some reason, a patient doesn't want to be treated, something that's a little difficult to imagine, or perhaps patients with very rare comorbidities that preclude the application of anything that will have yet been approved or at least adequately studied. So right now, for example, we need these fantastic regimens that we've seen so much about in the past few weeks alone at ESOL, in the New England Journal of Medicine, to be studied in patients with kidney failure, because doses have to be studied carefully in such patients, particularly with drugs that are excreted by the kidneys. We need much more robust studies in people with decompensated cirrhosis. But I have a feeling that in the not-too-distant future we will have sufficient data, even in those still challenging populations, to know what to use with confidence in those patients to ensure the highest levels of efficacy and safety. And I can't imagine that in the relatively near future we won't be treating just about everybody with hepatitis C, as long as we can get access to the medications.
Thank you for your attention. I hope you had enjoyed.